So now that we know what lipids and fatty acids are, we should begin our discussion in their biochemistry with how we acquire them, transport them to tissues that need them, metabolize them for energy or store them for later, and eliminate them in excess. This of course refers partly to their metabolism, which is a term that really means how our body manages and transforms these molecules for our purposes. However, I think a better approach for all of our macronutrients is to discuss what could be referred to as their macrokinetics, i.e. how we absorb them or acquire them, distribute them, i.e. transport them around our body, metabolize them, which means catabolize or anabolize them, and eliminate them. This will tell the full story of the nutrient, and then we will be much more equipped to discuss their biological and medical relevance. Let's start by talking about how we even acquire the fatty acids and cholesterol that are present in all of our cells in our body. Remember, we obtain these in two ways. First, by acquiring the lipids in our diet directly, and second, by creating them from scratch, called De-Novo biosynthesis, using other substrates, predominantly carbohydrates, as building materials. The key difference is that there are some materials we can't manufacture on our own, namely certain fatty acids with specific double bond orientations like omega-3 and 6 fatty acids, and certain lengths and orientations of monounsaturated and saturated fatty acids. We will discuss the importance of these later on. Cholesterol is entirely producible on our own, and although we do ingest cholesterol, it contributes negligibly to circulating levels. So let's start with a meal containing triglycerides and cholesterol. Ultimately, to get these into our circulation, we need to first break triglycerides into monoglycerides and free fatty acids for packaging, and two, push these molecules into micelles, or oil bubbles, that can transit the intestinal epithelium. The first digestion step happens in the mouth by lingual lipases, secreted by serous glands in the oral papillae, enzymes which can hydrolyze those triglycerides into a free fatty acid and mono or diglycerides. After making their way further down the alimentary tract and past gastric lipases in the stomach, they reach the duodenum, which of course receives biliary input from the pancreas and liver and gallbladder, which are secreting pancreatic lipases for further digestion into free fatty acids. The role of bile here, which contains bile salts, which are composed themselves of steroid acids like cholic acid, which is conjugated with glycine or taurine, plus cholesterol, is to emulsify fat in the duodenum. In other words, to promote the organization of fats into micelles, favorably from an organic chemistry perspective, which increases their surface area and accessibility by pancreatic lipase. If the biliary tree is obstructed, or the liver or pancreas is non-functional, fats are not fully absorbed and appear instead in the stool as steatorrhea, or white, thick, and fatty stools. Next, free fatty acids, now contained in micelles, are absorbed into the intestinal epithelium, where they are further assembled into lipoprotein particles called chylomicrons for delivery to the liver. Remember that highly lipophilic molecules like fat and cholesterol would not want to travel freely in the blood, more favorably being carried in oil bubbles or micelles to be transported in the circulation, and thus end up traveling in particles called lipoproteins, which we will discuss of great importance. Chylomicrons travel via lacteals, which are the lymph vessels in the intestines, and then join the portal blood via the thoracic duct. Cholesterol, on the other hand, can be absorbed and is reabsorbed or recycled, since it also appeared in the bile, via an intestinal and biliary tree receptor called Niemann-Pick C1-like 1 protein, or MPC1L1, which allows entry. Importantly, a pharmacologic agent known as ezetimibe inhibits this reabsorption and therefore reduces cholesterol recycling. Cholesterol itself is non-nutritive, but comes often esterified with a free fatty acid, which further makes it more likely to be absorbed, since it is even more lipophilic and is often transported in this esterified form. Importantly, the presence of lipid macromolecules transiting the intestinal tract leads to the release of several important hormones. Cholecystokinin, or CCK, released by duodenal and jejunal eye cells, in response to fat feeding, results in the contraction of the gallbladder, which assists in bile-assisted digestion of fats, as well as working as an appetite suppressant, reducing some drive for further intake. Another important hormone is GLP-1, glucagon-like peptide 1, which is secreted by L cells in the distal ileum and colon as a result of any feeding, carbs, fat, or protein, which is released into the hepatic portal system and does a variety of important postprandial jobs, mainly increasing glucose-dependent insulin release, which we will discuss with carb metabolism, but also inhibits gastric emptying and GI motility, which decreases appetite. This may be why certain patients on GLP-1 agonists have a reduced appetite, in addition to the central appetite suppressant effects of GLP-1 agonists, with some pharmacologic assistance in obesity management. As we've already alluded to, there are a variety of pathologies which can impair the process we've discussed so far, mostly in the absorption of fatty acids via 1. Stopping the release of lipases, like in pancreatic insufficiency, or destroying or damaging the intestinal brush border in such a way that it leads to difficulty in macronutrient transit across the intestinal epithelium. In the latter category, you'd expect malabsorption of all macronutrients, not just fats, the most important of which include celiac disease, which is an autoimmune-mediated intolerance to gliadin, which is a protein found in wheat, the main type of gluten, which is a larger umbrella term. Ingestion of gliadin specifically leads to an IgA-mediated anti-tissue transglutaminase release and inflammatory response, with subsequent decreased mucosal absorption in the distal duodenum and proximal jejunum. Diarrhea, steatorrhea, and weight loss occur over time, and some patients develop a rash called dermatitis herpetiformis, which is characteristic in 10% of patients with celiac disease. Because of the increased intestinal lymphocytosis, patients are at a moderately increased risk as well of T-cell lymphoma. Diagnosis and treatment can occur through a gluten-free diet. Lactose intolerance does not lead to fat malabsorption, but it could lead to diarrhea and increased transit time. Pancreatic insufficiency mostly occurs as a result of chronic pancreatitis, cystic fibrosis, or obstructive disease, and less common diseases like tropical sprue or Whipple disease may be infectious and require diagnosis by histopathology. Now we've absorbed our cholesterol, trace, really negligible, and fatty acids in the form of free fatty acids and monoglycerides, and they are sitting in our intestinal epithelium. Where do they head to next, and how do they get there? Think about all the places they need to go. They need to get to the liver first, if exogenously acquired, then be transported to all the cells in the body. What about the brain? And they also need a way out from the cells in our heart and vasculature, muscles, and other organs back to our liver for excretion through the biliary route for lipids not completely metabolized into products that they can be renally eliminated as. We've already stated that lipid molecules simply can't go floating around the blood due to their lipophilicity. Animals have evolved lipid-carrying protein lipid molecules called lipoproteins, which transport lipids in the way we've mentioned, to the liver from the intestines, from the liver to the periphery, and even from the periphery back into the liver. This careful management and receiving of lipid macrokinetics is the distribution of lipids and is regulated by the abundance and activity of specific types of lipoproteins, all of which carry triglycerides and cholesterol. When lipoproteins were first discovered, they were thought to be mostly the same molecule, until it was later found that fractionating the lipoproteins led to recognition of distinct lipoproteins by density after centrifugation. So for example, very low density lipoprotein versus high density lipoprotein. The clinical significance of the terms is negligible. They are antiquated terms that refer to this fractionation technique, but we need to know the differences between these particles. The key distinguishing feature between lipoproteins, which signifies their destination and shipping instructions, is their surface protein particle we call apolipoproteins. Apolipoproteins are a heavily researched group of surface proteins coating the outer membrane of lipoprotein particles and therefore often serve important enzymatic functions with the delivery and shipping of triglycerides and cholesterol around the body. For example, apolipoprotein B100 is found on the surface of lipoproteins which ship cholesterol and triglycerides towards the periphery, since ApoB is the ligand which binds the LDL receptor, triggering the drop-off of lipid molecules. In this way, we should divide lipoproteins functionally into three groups: ApoB48 containing lipoproteins, only chylomicrons; ApoB100 containing lipoproteins, which include very low density lipoprotein VLDL, intermediate density lipoprotein or IDL, and low density lipoprotein LDL, and lastly ApoA1 containing lipoproteins, the distinct HDL particle. Dividing them this way will be helpful later when we want to interpret a lipid biomarker panel correctly, understanding the biochemistry and the role of these particles. So how do our three groups of lipoproteins work, and what are their directionalities? Our first group, the ApoB48 particles, the chylomicrons, predominantly are triglyceride transporting lipoproteins for the exogenous lipid pathway, i.e. handling the majority of the fat we obtain in our diet. They pick up the fatty acids and esterified cholesterol from the intestine, ship it via lacteals to the liver, and then transport it to the periphery for use in other tissues like muscles and skin. Once ready to drop off, the signal to drop off is given by an enzyme called lipoprotein lipase, or LPL, which cleaves triglycerides carried in the particle into free fatty acid forms, which can then enter the destination cell. LPL is important here since its activity can be regulated to ask the body to increase fat storage, i.e. with increased LPL activity stimulated by insulin. Another enzyme called hormone-sensitive lipase asks the body to remove fat storage from deposited adipose tissue. Once chylomicrons have dropped off their package in the periphery, their structure is compromised and they become chylomicron remnants. It is from these remnants, which are studded with important apolipoproteins, not just ApoB48, which is degraded, that lead to the eventual formation of high-density lipoproteins, or HDL. Formation of HDL is complicated, but fundamentally requires the combination of triglycerides, cholesterol, and an apolipoprotein A1 molecule to create a nascent or young HDL particle. These components are combined in the liver by an enzyme called ABCA1. Without ABCA1, HDL cannot form. Mature HDL is formed once cholesterol inside is esterified by an enzyme called LCAT, or lecithin cholesterol acyltransferase, which requires ApoA1 as a cofactor. HDL then can circulate, stealing and grabbing cholesterol and triglycerides from peripheral tissues via ABCG1 in peripheral cells, but even from circulating chylomicrons and VLDL. HDL then finishes its delivery of reverse cholesterol transport back to the liver for clearance via different pathways. First, via the CETP pathway, the CETP pathway, which involves cholesterol ester transfer protein, or CETP, forcing HDL cholesterol to provide its cholesterol to ApoB particles in exchange for their triglycerides, which promotes degradation of the HDL particle and uptake of ApoB particles to hepatic LDL receptors. ApoE, another apolipoprotein, may allow HDL to be directly grabbed and degraded by the liver. The second pathway is the SRB1 pathway, involving the scavenger receptor class B type 1 pathway, responsible for grabbing HDL cholesterol without degrading the particle, allowing recycling of HDL. Now, where do the ApoB100 particles come in? Their main role is the management of cholesterol and triglycerides created via the endogenous production pathway, which we will discuss, but is of course the major pathway for cholesterol acquisition. Starting in the liver, triglycerides and cholesterol are packaged for peripheral transit after esterification via VLDL ApoB particles. Just like with chylomicrons, VLDL is cleaved in the periphery by LPL to drop off its triglycerides. However, instead, the VLDL remnants are known as IDL particles, which simply have less triglycerides and more cholesterol esters thanks to CETP. Circulating intermediate density lipoprotein is then returned to the liver for degradation, but some then becomes this important final lipoprotein, LDL, which predominantly carries cholesterol after losing ApoE via hepatic lipase. LDL carries excess cholesterol and can deliver it to the periphery appropriately. However, this process has been linked to the #1 cause of human mortality in atherosclerotic cardiovascular disease. The reason is that humans, more so than other animals, so it seems, maintain higher levels of chronic circulating LDL and ApoB containing particles over our lifespan. The theory is this prolonged residence time of ApoB particles in the circulation increases the probability of unnecessary drop-off in critical tissues, i.e. in the tunica intima, the inner layer of the arteries, and is probably related more to reduced clearance of these particles via hepatic LDL receptors than increased levels of ApoB particles. Regardless, while most LDL is eventually cleared by hepatic LDL receptors, the consequences of its residence in the blood over time compound and causally contribute to atherosclerotic cardiovascular disease, especially later in life. As a key point, all tissues need cholesterol, including the brain. which might be able to get it via apolipoprotein E containing lipoproteins, and although too little circulating lipoproteins may contribute to problems via low access for the brain in rare circumstances, mainly when we cut off de novo biosynthesis, too many lipoprotein particles constantly in circulation, specifically ApoB100 containing, have an area under the curve like exposure-mediated effect over our lifespan on the development of atherosclerotic cardiovascular disease, many of us whom, including those of us in our 20s, already are unknowingly affected by. Now, importantly, let's make sure we're all on the same page here. Nutritionally speaking, all of the 4 fatty acids, MUFAs, PUFAs, SFAs, and TFAs, are mostly consumed as components of triglycerides in the diet. Consuming dietary triglycerides clearly has a different effect on our lipoprotein concentrations than it would with de novo synthesized triglycerides, since they engage in the exogenous pathway and increase chylomicron concentrations, which are not often measured, instead of the endogenous pathway with VLDL concentrations increasing. What is interesting is the effect we see observationally on how different MUFA to PUFA to SFA to TFA ratios in the diet, i.e. how much saturated fat you intake compared to how much monounsaturated fats you intake and so on, affect our circulating triglycerides. Remember, circulating triglycerides are measured from all 3 of chylomicrons, the exogenous pathway, but also VLDL, our endogenous pathway, or remnant particles. If all of these fatty acid types are carried in triglycerides, why would consuming all 4 of them not simply just increase triglycerides via the exogenous pathway? Interestingly, MUFAs and PUFAs have been demonstrated to actually lead to relative decreases in circulating triglycerides. You'd expect the opposite, whereas saturated fats and trans fats may increase triglycerides as expected. First, it's important to recognize, of course, the dietary zero-sum game applies. If you switch to a diet higher in certain things like MUFAs, you may be reducing overall calories, which could reduce circulating triglycerides, but we'll allow for the assumption that this mechanism holds. Some have postulated that MUFAs and PUFAs may be able to downregulate the endogenous pathway in a way that saturated fatty acids do not. I have a feeling, although there may be sound and negative feedback loops in terms of MUFA to PUFA downregulation of the endogenous pathway, we may be playing a zero-sum game. If we are eating more MUFAs and PUFAs and less carbohydrates, this could contribute to lower production of endogenous SFAs and thus lower triglycerides. And if we are eating a lot of saturated fats exogenously, this would also simply increase triglycerides. Regardless, some observational literature points towards signals of improved clinical outcomes with PUFA and MUFA intake relatively to high saturated fat intake. And the mechanism could be 1. Lower overall calorie intake, but also 2. Plausible biologically incomplete mechanisms that reduce VLDL production via reduced endogenous triglyceride production and subsequently less circulating ApoB100 particles, which is known to be causally linked to ASCVD. Bottom line, maybe we can use our exogenous pathway more favorably than our endogenous pathway, since the latter relies on ApoB particles, and perhaps shift towards those which reduce the need to use our endogenous pathway, like MUFAs and PUFAs, proportionally over SFAs and TFAs. HDL cholesterol, when I learned it in school, was taught like it was some form of positive cholesterol, since it was weakly associated with improved clinical outcomes. Although not causally associated, it is clear and mechanistically sound that patients who have high HDL must have high remnant chylomicrons. Those who are efficient at metabolizing and clearing plasma triglyceride from chylomicrons. What seems to be a good way to interpret HDL is as an inverse barometer of triglyceride metabolism, where hemoglobin A1C is a barometer of glucose metabolism. The higher the HDL is, the lower the triglycerides are, which may be clinically relevant from a metabolic health perspective. Patients who have higher HDL and lower TG profiles are probably metabolically healthy from a fat metabolism perspective. As a side note, I introduced another apolipoprotein E. ApoE is interesting since it's present on both HDL and ApoB containing particles and significantly interacts with the LDL receptor. Suffice to say, it may act as a partial regulator of lipoprotein uptake in tissues and clearance, but some other important takeaways are currently known. 1. ApoE gene mutants have been identified which correlate well with the risk of Alzheimer's disease, particularly in those who carry an ApoE4 variant. 2, ApoE appears to be the main cholesterol carrier in the brain, taking cholesterol to brain tissue and removing it from brain tissue. And third, ApoE4 mutants may also have interesting problems with insulin-sensitive GLUT channels and perhaps have an increased risk of insulin resistance, and thus introduces an interesting relationship between ApoE and metabolic dysfunction, perhaps emphasizing the importance of these dietary principles in ApoE4 variant populations. Now, I've touched on the problems with increased retention time of ApoB-containing particles in atherosclerosis, so let's just put a bow on that by reviewing atherosclerosis from a pathophysiology and assessment perspective. Atherosclerosis is, of course, a pathological and maladaptive process that involves the development of a lumen-restricting plaque in the arterial wall that can lead to thromboembolism and ischemia of an artery, affecting all arteries, but most immediately, devastatingly, the coronary arteries, aorta, carotid arteries, and the arteries of the circle of Willis. Most humans on autopsy will have some atherosclerosis noticeable, even 20-year-olds, and the damage is cumulative, meaning the longer we wait to interrupt or slow this process, the harder it will be to prevent catastrophic events later in life. Atherosclerosis occurs in a series of well-described steps. First, the infiltration of macrophages into the tunica intima and its transformation into a foam cell, since they look foamy under a microscope, really because they are lipid-laden, meaning that the macrophage at the site has taken in cholesterol from an ApoB-containing particle. This step is invisible to the naked eye and begins in the first decade of life. Second, the generation of the fatty streak, or the earliest visible lesion of lipid-laden foam cell accumulation in the artery. And third, the intermediate lesion, where small extracellular lipid pools, which leads to fourth, the atheroma formation, which involves the generation of a core of spilled over extracellular lipid. Fifth, the fibroatheroma with multiple lipid cores and fibrotic and calcified lesions, now detectable via imaging techniques like the calcium score, since calcium deposits are a marker of vascular damage. And then lastly, sixth, a complicated lesion where the fibrous cap may rupture and result in a surface defect, leading to platelet aggregation at the site and thrombosis or hemorrhage or hematoma. It is once a patient is in step 5 or later that symptoms may appear, but this is just the tip of the iceberg of what pathologically has occurred, and unfortunately, sudden cardiac death may be the first symptom of this process. Historically, when we first learned to measure cholesterol content in the blood via lipoproteins, the LDL-C, or LDL cholesterol content, was correlated well with the risk of atherosclerotic cardiovascular disease. This is somewhat unsurprising, but was unrefined, since it isn't exactly the cholesterol amount we're concerned about, but the number of ApoB-containing particles that the arteries are exposed to over time. Currently, the best predictor of ASCVD from a lipid biomarker perspective is the ApoB concentration, since all ApoB 100 containing particles only contain one ApoB molecule on their surface, which literally allows us to count the ApoB particles. Consistently, the more ApoB particles you have, the higher your risk, and this has been corroborated in Mendelian randomization studies, establishing the causal link. LDL-P, or LDL particle number, gives us a better but incomplete picture, since we would be missing the contribution of other ApoB-containing particles like VLDL and IDL. Non-HDLC tries to summate these ApoB-containing particles concentrations, but again measures the cholesterol content and not the particle number. Luckily for most patients, the concentration of cholesterol is roughly correlated to the particle number, but in discordance analyses, ApoB performs better consistently than non-HDLC when there are variable sizes of particles at play in specific patients. Further, when triglyceride levels are low, we expect VLDL to be very low, and LDL is then likely to make the majority of the ApoB particle-associated risk. Lastly, but importantly, some subtypes of particles have been identified which may play an outsized risk as a subset of ApoB 100 containing particles, namely Lp(a), which is an apo(a) containing particle, which is bound to LDL ApoB particles and is genetically driven, giving some patients an outsized risk when high, but also some other things like small dense LDL, which may play a more important role in ASCVD than large buoyant LDL. Regardless, as a summation, the AUC-mediated exposure effect of ApoB particles is clearly related to ASCVD, and in patients with high LDL or ApoB, even in patients with levels inside the reference range, exposure over time can be reduced through some pharmacologic means to reduce long-term risk. And as we now know, dietary measures make sense for high VLDL, but not for high LDL. So in patients with low triglycerides but high LDL or ApoB, pharmacology is probably chief over dietary interventions like fat ratio manipulation. As a final point, lack of or a dysfunctional LDL receptor is commonly thought to be an important reason for increased circulating time of ApoB particles. One of the many reasons is an endogenous molecule called PCSK9, which stands for proprotein convertase subtolysine kexin type 9, an enzyme that targets the LDL receptor for degradation. You can imagine gain of function mutations in the PCSK9 gene could lead to hyper-ApoB, and this is exactly the case. A class of relatively new drugs, although not so old anymore, called PCSK9 inhibitors have been produced and have effectiveness at increasing effective clearance of ApoB particles via inhibition of this molecule's activity. Choosing agents for atherosclerosis requires a case-by-case basis analysis, but generally, some combination of reduced de novo biosynthesis, reduced enterohepatic recirculation, and possibly reduced PCSK9 activity is generally effective for improving these risk factors, which has been corroborated to improve clinical outcomes, although long-term outcomes in those started very young is lacking outside of those with familial hypercholesterolemia. As a quick cardiology and preventative medicine correlate, we are aware of a group of problems collectively known as dyslipidemias, which is a broad umbrella term for many heterogeneous genetic and secondary problems which affect lipoprotein metabolism. We also call many of these problems hypercholesterolemias, but again, as we know, high cholesterol may not be the problem, but the abundance of lipoproteins or even absence. Hypercholesterolemia, however, in particular, may be interesting if it relates directly to higher ApoB particle number, and in fact, several diseases have been identified which, as you would expect, are causally linked to increased ASCVD risk. The well-studied dyslipidemia that is primary is familial hypercholesterolemia, or FH, which can be homozygous, worse, or heterozygous, which is less pronounced, which is an autosomal dominant and results in loss of function in the LDL receptor. As you'd expect, a very high ApoB and LDL particle number in the blood in these patients, and a subsequent risk of ASCVD. Other dyslipidemias may involve those which can cause PCSK9 gain of function or involve some other mechanism by which either the LDL receptor is less functional or abundant, or the ApoB particles are produced in greater numbers. Regardless of the problem, patients with these genetic factors, as you'd expect, typically require pharmacotherapy, since the only dietary method of intervention involves reducing the VLDL component of the ApoB equation, which is not the problem here. Diet and lifestyle changes may instead play accessory roles in the health span and lifespan of these patients, for example with metabolic health. Much less common problems include hyperchylomicronemia, an autosomal recessive problem. You can guess that this leads to elevated plasma chylomicrons and triglycerides, and the consequences thereof of hyper-TG include pancreatitis, eruptive xanthomas, but not atherosclerotic cardiovascular disease because there are no ApoB100 particles involved. Dysbeta-lipoproteinemia is another uncommon autosomal recessive problem where there is a defective apolipoprotein E causing elevated VLDL and chylomicrons, and since VLDL carries ApoB, patients do have an increased risk of ASCVD. As we've already alluded to, some other diseases like insulin resistance and type 2 diabetes spectrum disorders can affect our lipoprotein concentrations, since insulin is a regulator of LPL activity and promotes lipogenesis. Insulin resistance would lead to lower LPL activity, which would subsequently drop HDL and increase circulating triglycerides. Increased triglycerides could lead to increased VLDL production and atherosclerotic cardiovascular disease risk, in addition to causing frank changes in these lipoproteins. Other diseases like CKD, hypothyroidism, and alcohol overuse appear to contribute in complex ways to dyslipidemias. I would learn this list to consider them, but then approach a patient with a clinical gestalt of first, ruling out frank genetic components to high ApoB, and then second, managing as best as we can the metabolic component of high VLDL through high triglycerides. As a frank clinical example of the effects of high circulating cholesterol carried in ApoB particles in the blood, some patients have frankly noticeable physical exam findings which give this problem away and which make the stronger case for a genetically mediated component to their disease. Notice these xanthomas, plaques or nodules composed of lipid-laden histiocytes or macrophages in the skin, especially around the eyelids, which we call xanthelasma. Tendinous xanthomas in the center may be noticeable here on the Achilles tendon, and corneal arcus, this pale ring around the iris, sometimes called arcus senilis, occurs later in life with high ApoB particulemia. This is a reminder that circulating lipids do not account for total body storage of lipids. To finish up with lipid distribution, let's quickly run through some pharmacologic mechanisms we have to reduce our lipids in our circulation. The most common method is through statins, or HMG-CoA reductase inhibitors, as we'll see, which both decrease de novo biosynthesis of cholesterol, but second, also increase hepatic LDL receptor expression, which helps to clear ApoB particles in the blood. Bile acid resins tie up bile salts and reduce dietary fat absorption, and this leads to intentional steatorrhea, not obviously the typical first go-to treatment, but we can see how this could assist with high triglyceride diets. Ezetimibe, as we've mentioned, blocks enterohepatic recirculation of cholesterol through MPC1L1 blockage. PCSK9 inhibitors stop that molecule PCSK9 from targeting the LDL receptor for degradation, and a few last interesting options exist. Fibrates, now less in favor but still for hypertriglyceridemia, are agents which probably activate a protein called PPAR alpha, which activates LPL, promoting the reduction in circulating triglycerides from chylomicrons and VLDL. Niacin, of course, which is just vitamin B3, appears to change lipoprotein ratios, perhaps through enzymatic cofactor-related metabolism of apolipoproteins, although no strong clinical outcomes have been noticed with its use. Lastly, we've already described how MUFAs and PUFAs may decrease triglycerides specifically, which could reduce VLDL. Before we get into metabolism, let's finish by discussing how we go about getting rid of excess lipids. Cholesterol is simply recycled over and over as it transits your gut as bile acids and is reabsorbed, some being trace removed in the feces. But fatty acids, of course, are packed into adipose tissue, and instead of excreting excess fatty acids, we are more likely to metabolize them for energy. Whereas carbohydrates cannot overaccumulate due to spatial restrictions with water in glycogen, and protein accumulation only occurs in muscle building requiring a high demand environment with resistance training, fat overaccumulation instead will more likely lead to spillover into non-adipose tissue, i.e. in muscle, liver, and other organs, which can lead to insulin resistance over time. Let's, however, finish by discussing the bile salt in cholesterol excretion pathway. A major function of cholesterol is its presence in the composition of bile salts, which, as we've said, are carried in bile with cholic acid with glycine or taurine to emulsify fats. Bile acid synthesis is regulated by an enzyme called cholesterol 7-alpha hydroxylase, a cytochrome P450 enzyme, which is the rate-limiting step of bile acid synthesis. There are multiple problems which can arise from either the overaccumulation of cholesterol in the bile or the relative absence of it. First, absence of cholesterol in bile, of course, leads to fat malabsorption, but another key problem this leads to is free oxalate absorption. Oxalate is typically bound up to dietary calcium, but when there is too much fat in the stools, calcium is bound instead to fat, and high oxalate accumulates in the blood and is cleared by the kidney, often leading to precipitation in the ureter or renal pelvis, causing calcium oxalate kidney stones, the most common type of kidney stone. High cholesterol, on the other hand, in the bile may lead to stones as well, but this time cholesterol gallstones, seen in the left picture below, which can block the ductal system of the biliary tree and cause pain, rupture, or infection depending on the circumstances. If the stone blocks the cystic duct but does not cause infection, we call this cholelithiasis. With infection, we call it cholecystitis. Stone migration and blockage of the common bile duct is called choledocholithiasis, and infection at this level would be known as cholangitis. Gallstones can also obstruct the pancreatic duct, leading to pancreatitis. And although unrelated, another type of gallstone, the pigmented gallstone, can occur as a result of excess bilirubin in the bile. Why would so much bilirubin appear in the bile? Think of high red blood cell destruction and thus excess clearance of waste in the context primarily of hemolysis. As described, think of where the stone has landed, almost always a cholesterol stone, to figure out the location of disease and thus the management. Cholesterol stones can be due to high cholesterol in the bile or reduced bile salts and gallbladder stasis, i.e. in the lack of contractility. These are most associated with older multiparous females, but occur in almost all ages, representing 80% of gallstone type, and are radiolucent, meaning they're 10 to 20% opaque with calcium, thus only casting a shadow invisible on the abdominal X-ray. Pigmented stones, however, are radio-opaque and more easily visible. Interestingly, there is an association between rapid weight loss and caloric restriction and gallstone formation, perhaps due to increased adipose tissue and fat mobilization. Gallbladder removal, cholecystectomy, can be curative for recurrent gallstone disease due to the loss of this stasis problem. A rare problem called porcelain gallbladder may result from chronic gallstones and is often found incidentally on imaging, but may be a risk factor for adenocarcinoma of the biliary tree. Now, finally, we come to the metabolism of lipids. The word metabolism can be misused frequently, so I think although it's certainly appropriate, we should begin to think more intentionally about the directionality of the metabolism, which really refers to how our body is processing lipids, which occurs in two opposite directions. Anabolism, which refers to building fat storage, and catabolism, which refers to breaking down storage or free fatty acids for parts. In this way, we'll discuss anabolism and catabolism separately to be clear with regards to what is happening and the hormonal and cellular regulators of this. Importantly, however, we need to make crystal clear the primary driving force in the decision making between anabolism and catabolism, and that is the energy balance. I think that when medical students are learning biochemistry and when most people are thinking about nutrition, there is this assumption sort of de facto that people are always eating an amount of food in such a way that leads to their body weight being perfectly stable. While generally speaking, this could hold true at a population level, it breaks down very quickly when you are looking at an individual person. And specifically, when thinking about the application of the knowledge of biochemistry, you need to think about the specific circumstances of an individual's nutrition when considering how these things are playing out. What I really mean to say is the main driver for fuel catabolism is a calorie deficit, i.e. the state of an individual either restricting calories on purpose or involuntarily. The hormonal consequences of this certainly open the doors, so to speak, of the precise mechanisms of fuel partitioning and breakdown, but the cause of the process is the calorie deficit. Without enough calories to supply your maintenance, aka your basic functions and energy demand throughout the day, you must strip and access fuel storage from the body, mainly glycogen in the muscle and liver and adipose tissue. Conversely, the main engine driving fat anabolism or any anabolism is a caloric surplus, meaning you won't pack on fat storage or glycogen storage unless you are able to surpass your basic requirements first. I think this is important because it highlights the two key clinical nutritional principles. We need to think about nutrition from first, an intentional energy balance, i.e. are we eating enough, too much, or too little for our goals? And second, a nutritional composition perspective, i.e. what are we eating? We will find and already have found that certain forms of our macronutrients behave differently in metabolism and distribution, but this is secondary to the energy balance required to push them in that direction. In reality, most people who do not track what they eat and keep no consistent diet from day to day end up oscillating somewhere above and below their maintenance calories or number of calories needed to maintain their current weight, even within the same day. Periods of times without food, aka fasting, then sudden overfeeding represent oscillations between the opportunity to perform fuel anabolism and fuel catabolism. So realize that both of these processes are happening constantly and alternating. We will discuss how both processes occur, but we are able to control the net directionality of this homeostasis with behavioral change, aka purposeful and intentional careful caloric restriction can lead to a prolonged and sustained net directionality in the fat catabolism direction, whereas sustained and intentional or unintentional overfeeding will lead to a net directionality of a fat anabolism. Now, from a bird's eye overview, we can see that really what we are doing by anabolizing fats is partly taking our dietary free fatty acids in the form of triglycerides and storing them into adipose tissue, which is designed for long-term storage. We already know how to do this using lipoprotein lipase, or LPL, stimulated by insulin. However, we will discuss the endogenous pathway of lipogenesis in fatty acid synthesis, which occurs when we have a surplus of carbohydrate precursors, importantly fructose, to also contribute to this process, stored in the same way but carried by VLDL particles. Fat catabolism, on the other hand, in a calorie deficit, occurs as a result of removal of fat from these stores, leading to a catabolic process of energy retrieval from fatty acids called beta-oxidation, which we will discuss. Our body is stimulated via a calorie deficit to undergo lipolysis by hormones like growth hormone, glucagon, and epinephrine. An interesting observation is the role of growth hormone, which we will discuss in the steroids section, which peaks in adolescence and falls by age 21. Notice that you are chubbier than you were in high school. A calorie surplus is probably to blame, but when you felt like you could eat anything without gaining weight, perhaps the growth hormone was pushing the homeostatic needle towards the catabolism side in your favor. So let's start with fat anabolism by exploring our endogenous lipogenesis pathway, clearly an evolved strategy to use surplus carbohydrates and convert them into a form that can be stored long term. In contrast to fats, carbohydrates are hard to store long term. As you'd expect, they are highly branched, taking up a lot of space, but also hydrophilic and carry water with them wherever they go. Hence, if you've ever been in a caloric restriction, you'll know what I mean by feeling flat. The glycogen stores in your muscles get depleted, and thus so does the water, and this usually takes up a lot of space anatomically. Fat, however, can be packaged extremely tightly into adipose tissue, and so taking carbohydrate metabolites and converting them into fat is advantageous, but requires some energy input, which will pay off later. Importantly, however, as we'll discuss in carbohydrate biochemistry, fructose is very important, since it is much more likely to lead to fatty acid synthesis via its metabolites than glucose. But why? We will discuss how the rapid and passive absorption of fructose, as well as the minimally regulated fructolysis, leads to rapid development of our necessary precursor for fatty acid synthesis, acetyl-CoA. And therefore, despite an energy surplus, where we would typically pack up glucose as glycogen, we end up favorably packing fructose as fat. Hence, fructose intake, nutritionally speaking, is a main determinant of how much we are using our endogenous pathway, remember, which may be less favorable from a lipoprotein perspective than obtaining our fats through the diet. And of course, how come we do not just continue straight through the Krebs cycle once we accumulate acetyl-CoA from glucose or fructose? Well, we have negative feedback loops in states of energy surplus that stop this via isocitrate dehydrogenase, the rate-limiting step of the Krebs cycle, which experiences negative feedback from excess ATP, leading to accumulation of citrate, and thus acetyl-CoA will accumulate instead of becoming citrate. Thus, we can use these extra energy substrates for fat storage. But how exactly do we do this? Let's make this process as clear and simple as possible: the lipogenesis pathway, or De-Novo biosynthesis of fatty acids. Divide the process first into two big sections. First, NADPH generation, which we'll need for later, and then second, actual fatty acid synthesis. For the first section, we need to ultimately obtain a molecule called nicotinamide adenine dinucleotide phosphate, or NADPH, to power the machinery for fatty acid synthesis. And we obtain this special molecule by taking our extra citrate that is accumulating in the mitochondria and metabolizing it to pyruvate. First, the citrate shuttle helps it escape. Citrate lyase, then splitting citrate into acetyl-CoA, which can contribute to our surplus acetyl-CoA, and oxaloacetate. Oxaloacetate is then converted into malate and then pyruvate by malic enzyme, providing us a byproduct with NADPH. Now finally, fatty acid synthesis can begin. The pyruvate we just made can re-enter the mitochondria and turn back into oxaloacetate by pyruvate carboxylase. Fatty acid synthesis is simple and occurs in the liver, mammary glands, and adipose tissue, specifically in the cytoplasm, although initial steps required in the mitochondria, and simply takes an acetyl-CoA, a 2-carbon molecule, adds a carbon to it to make it malonyl-CoA via the rate-limiting enzyme acetyl-CoA carboxylase and enters a multi-complex enzyme machine called fatty acid synthase, which polymerizes acetyl-CoA plus 2 carbons onto the malonyl-CoA skeleton to make the 16-carbon fatty acid palmitic acid after 7 rounds, since 3 to start with, but a carbon dioxide molecule falls off immediately. Then you add 14 carbons added in 7 acetyl-CoA molecules. The net reaction is 7 ATP is required, plus 8 acetyl-CoA in total, with 14 NADPH molecules to create 1 palmitic acid plus 6 water molecules. This form of biosynthesis is possible in both mammals and fungi, and so it's quite ancient and qualifies as non-template biosynthesis, where no template was required to make it on our own, similar to glycogen synthesis, in contrast to protein synthesis, for example, which requires an mRNA template. As a final clinical note on this process, an important moment to make a note about enzymatic cofactors, in particular for groups of enzymes like carboxylases, which incorporate carbon atoms into an organic substrate. A feature of many carboxylase enzymes is that they require the cofactor vitamin B7 or biotin, which is then also required for fatty acid synthesis. Luckily, biotin is nearly impossible to become deficient in, since our intestinal bacteria can make it for us. Another example of a carboxylase is the vitamin K-dependent carboxylase, which activates a variety of clotting factors. Consider in metabolic pathways when common molecules like vitamins may be necessary for function. So now we have both the palmitic acid we've created ourselves from fatty acid synthesis, as well as our dietary triglycerides with fatty acids attached. But where do we store these for later? Of course, the answer is in adipose tissue, which is now recognized as a quite complex organ with endocrine functions, which we'll discuss. Remember that they don't simply appear in fat tissue. They are transported either by chylomicrons for dietary fat or VLDL for the endogenous pathway, and are signaled to pack into adipose tissue by lipoprotein lipase via insulin. But let's talk about what adipose tissue really is. Adipose tissue is an organ made from adipocytes, fat cells with large vacuoles for fat storage, but also serves some other purposes like structural protection, specifically in subcutaneous tissue, but also things like thermogenesis and insulation, in particular with brown fat, as we'll specify. But adipose tissue has also been found and is more recently studied to have endocrine functions, specifically producing its own hormones and signaling molecules, not only in a paracrine or autocrine fashion, but endocrine to the rest of the body. A few of the main hormones that adipose tissue is responsible for are leptin, which is the satiety hormone. The more you secrete, the less hungry you are, but also estrogen, specifically converting precursor androgens into estrogen. Adipose tissue is also responsible for inflammatory cytokines, which of course serve a useful purpose if you need to be inflammatory like in an infection, but unfortunately the inflammatory nature of excess adipose tissue is one of the postulated mechanisms by which obesity is a leading risk factor for all forms of cancer. Leptin does not oppose insulin, but by decreasing hunger, it can reduce food intake, which reduces insulin release and thus could mediate removal of fat mass. But remember, the only primary driver of fat loss is a calorie deficit. We can already tell that fat mass in adipose tissue probably has some positive effects, hence its evolution, but the problem is probably dose, i.e., some adipose tissue is good, too much is almost definitely bad. The question is how much, and if we can change the size of the organ at all with behavioral change. On the topic of volume of adipose tissue, it's important to realize the differences between different locations of adipose storage and some interesting mechanistic differences. Clearly, there are some specific body sites in which adipose tissue, subcutaneous adipose tissue, is stored more preferentially than others. We call these adipose depots, and the most common sites are in the abdomen surrounding and encapsulating the abdominal organs, in the thighs, and in the gluteal regions, with generally less subcu tissue surrounding the neck and arms. Subcutaneous or visible fat accounts for 90% of fat storage, importantly, and is considered actually to be the preferential adipose storage location for most fat mass and may be metabolically healthy, i.e. in a dose-dependent fashion. Having some amount of subcu adipose tissue seems to be appropriate. This is in contrast to visceral fat mass, which refers to the adiposity beneath the fascia surrounding and infiltrating organs. VFM, in particular abundance of VFM, has been linked clearly to several pathologic conditions, including insulin resistance, as we've described, but also increased risk of cancer, prolonged hospital stay, even mortality and infectious risks. What seems to be the case is that VFM, disproportionately compared to sub-Q mass, is endocrinologically active in specific ways, meaning perhaps releasing more inflammatory mediators and cytokines than sub-Q mass, and potentially reduces the amount of adiponectin secreted, which is usually secreted by subcutaneous mass, which helps with glucose metabolism and lipolysis. In contrast to sub-Q fat, which may be protective in some ways in small amounts, we don't want to see nearly any visceral fat mass accumulation, or at least much less. And unfortunately, patients with very little or seemingly normal amounts of subcutaneous fat can have an overabundance of visceral fat mass, only detectable with one, DEXA scanning, or more accurately MRI, or second, with the consequences of visceral adiposity, namely hints of insulin resistance, non-alcoholic fatty liver disease, or other metabolic disruptions. The question of how much fat mass is acceptable is a difficult one and should probably be split up between subcutaneous and visceral fat mass. However, traditional scanners like DEXA machines will report body fat percentage with some error, of course. This number is taken to be important, but perhaps from a medical perspective, reducing visceral fat as much as feasible within reason should be a separate goal from reducing subcutaneous body fat. Or in addition, reducing total body fat mass, including sub-Q mass, can be used as a tool or proxy assist to reducing visceral fat, since of course, in a caloric deficit, all fat stores will be accessed, including visceral fat. But what would be our floor for subcutaneous tissue we would consider healthy? This optimal range of body fat percentage is not well elucidated. At the moment, the American College of Sports Medicine calls greater than 19% body fat overweight for males and greater than 32% body fat percentage for females overweight. Perhaps essential body fat being 3% of total body weight for males and 12% for males. Are we okay with our patients staying around 4% body fat for men? The answer may be probably not, and again may be a perspectival problem. Perhaps the lower the better may make sense generally speaking from a population level, but at an individual level, you will be balancing things like tolerability, hunger, subjective energy levels, satisfaction, difficulty with further reductions, loose skin, and other things when deciding whether to continue pushing the body fat percentage down, and probably will organically come to a point where sub-Q fat and visceral fat mass are at a level where they are as low as they can be practically achieved for a sustained period with excellent tolerability and improved health and well-being. Remember, of course, that adipose tissue is not simply made solely of adipocytes, although adipocytes make up most of the volume. There are also immune cells like macrophages, stem cells, neurons, and fibroblasts involved, which explains the milieu of inflammatory regulatory mechanisms associated with an abundance of adiposity. But to finish off, you may have heard of white versus brown fat. Simply speaking, most of us have very little brown fat, much more important when we were neonates to help us with maintaining a healthy body temperature, since brown fat has programming that assists it in undergoing purposeful futile metabolic cycles, which lead to heat generation without ATP generation, specifically for thermoregulation. White fat is the adipose tissue we typically think of. Can we transform white adipose tissue to brown? It is unclear, and although some think that exercise might do this over time, it may be a relative decrease in percentage of white fat, thus increases in appearances of percentage of brown fat. Now we know how to anabolize fats, specifically fatty acids from carbohydrates, and how to pack them into storage containers. The other important lipid molecule we anabolize is cholesterol, of course. All or nearly all of our circulating and tissue cholesterol is made on our own via De-Novo cholesterol biosynthesis, aka the dietary cholesterol we intake is only trace responsible for this process and mostly excreted in the bile. Therefore, it is important to understand this process clearly. Further, cholesterol synthesis is the pharmacologic target for many agents which were invented on the basis of the original belief that cholesterol amount was the problem, later finding that reducing cholesterol synthesis could have pleiotropic effects on lipoproteins responsible for atherosclerotic cardiovascular disease. Remember, we need cholesterol everywhere, including the brain. Neonates have very little cholesterol, but need it critically, especially for central nervous system development, and thus we are highly evolved to make this on our own. The process by which we create cholesterol on our own overall is called the mevalonate pathway, but as we'll see, leads to a point where we reach lanosterol. There are two branch points after which result in two different ways to create the final molecule cholesterol. We can do this in most cells in our body, but this is mostly done in the liver. We already know that we can obtain acetyl-CoA through carbohydrate precursors or through beta-oxidation of fatty acids. These acetyl-CoA molecules are transformed first into an important intermediate called HMG-CoA, or 3-hydroxy-3-methylglucaryl-CoA. Remember, coenzyme A really being a metabolite of vitamin B5 or pantothenic acid. HMG-CoA is then transformed into mevalonic acid by the important statin target HMG-CoA reductase, which can be inhibited to reduce but not completely inhibit this process, leading to reductions in cholesterol synthesis but not 100% inactivity. Statin-mediated interruption of this enzymatic reaction is probably dose-dependent. We see that when we give a smaller dose of a statin or a higher dose of a more potent statin, lipoprotein reduction varies, and thus, conceivably, we could shut this process down completely, which would not be ideal. Many other steps occur afterwards, leading eventually to squalene generation and then lanosterol generation. Lanosterol being a common ancestral intermediate we even share with fungus, eventually becoming ergosterol instead of cholesterol in animals. Interestingly, bisphosphonates also target this pathway in farnesyl pyrophosphate synthase inhibition. Indeed, bisphosphonate administration leads to reduction in cholesterol synthesis to a minor extent and even reduces ApoB, similar to low-intensity statins. However, the other effects of bisphosphonates, namely affecting the homeostasis of bone resorption and formation, lead this to be a non-ideal therapy specifically for ApoB reduction. Once we get to lanosterol, there have been two identified pathways that both eventually lead to cholesterol. They are interrelated, as you can see, the block pathway being able to create intermediates that continue down the Canduce-Russell pathway, but not the other way around. We create desmosterol with the block pathway, but do not create it with the Canduce-Russell pathway. An important drug and cautionary tale that was discovered but no longer used was called triperenol, that was able to prevent the transformation of any block pathway intermediates into the KR path, thus preventing cholesterol formation entirely. It was thought initially this was a good idea. The drug was later withdrawn in 1962 because of irreversible cataract formation, skin disorders including fish scale texture, itching, and peeling, and in fact a higher atherosclerotic cardiovascular disease risk, which was the consequence of high accumulation of desmosterol in the blood. As it turns out, completely shutting down this pathway is a bad idea. HMG-CoA reductase inhibition reduces it greatly but does not completely inhibit the process. What might be interesting instead may be understanding from a treatment perspective on the extent of cholesterol de novo biosynthesis in patients being treated with lipid-lowering therapies by measuring desmosterol and lithosterol as indicators of synthetic function. In patients in whom are being treated with high-dose or multi-agent strategies to reduce ApoB, measuring these sterile precursors may give an indication on the extent that this pathway is suppressed, which could be potentially prognostic for concerns with the treatment effect on things like our central nervous system health, since low desmosterol has been associated with cognitive impairment and metabolic health, i.e., still desiring some cholesterol synthesis, but reduced acceptably. But that does it for fat anabolism. We know how we fully create, synthesize, and store fatty acids driven by a net caloric surplus and cholesterol. Now let's shift to discussing fat catabolism, occurring in states of a net caloric deficit, i.e. a situation in which our body would favor stripping from our stores or immediately catabolizing dietary fatty acids for energy. The process by which we strip fatty acids for energy is called beta-oxidation, which, as we'll see, involves the oxidation of the fatty acid, remember, which usually involves removing hydrogen atoms, creating double bonds in their place, which gives us a free energetic proton through NADH or FADH2 to run through the electron transport chain. The key with beta-oxidation is this process must occur in the mitochondria, specifically in the mitochondrial matrix, and thus is a slower energy retrieval system than glycolysis, which yields immediate cytosolic ATP. In the long run, fat oxidation lets leads to more energy and more sustained, reliable energy with such vast storages? And is this system of energy more associated with long sustained aerobic exercise or demand? Remember that the Krebs cycle and the electron transport chain require oxygen for use, and so beta oxidation is a form of aerobic metabolism. Glycolysis is not. In order to begin beta oxidation, we first need to get the fatty acid into the mitochondria from the cytoplasm. This requires two steps. First, fatty acid activation by CoA tagging, which requires 2 ATP. Remember this for accounting. But then second, the rate-limiting step of catabolism, the transport into the mitochondrial membrane. Short chain 1 to 6 carbons or medium chain fatty acids, which are 7 to 14 carbons long, can simply head to the mitochondria, but greater than 14 to 20 carbon chains must use something called the carnitine shuttle, which requires adding carnitine to the acyl-CoA through the rate-limiting enzyme carnitine acetyltransferase 1. Once the longer acyl-CoA reaches the matrix, the carnitine can be removed. But now we can perform beta oxidation. Let's make it as easy and simple as possible to remember. The 4 steps of energy retrieval from our acyl-CoA can be remembered as OHOT, which is oxidation, hydration, oxidation again, and thiolysis. We only earn energy directly in our O steps, but then also gain +1 acetyl-CoA at the end of every cycle. Take a look at our schematic on the right. We add a double bond, pulling off a hydrogen atom for FADH2 in the first O, then turn an alcohol into a ketone in our second O step, gaining 1 for NADH. That alone was 1.5 ATP for the FADH2 and 2.5 ATP for the NADH, giving 4 ATP just from one cycle. Each cycle, therefore, we get 4 ATP from energy carriers and 1 acetyl-CoA, which can enter the Krebs cycle. The process continues until only 1 acetyl-CoA remains. Some quick accounting. For even-numbered long-chain fatty acids, this means we could get half the long chain in acetyl-CoA. So for example, 8 acetyl-CoA for a palmitic acid, plus 4 ATP for every cycle. For odd-numbered long-chain fatty acids, we get C minus 3 divided by 2, meaning one moiety will be a 3-carbon containing molecule called propionyl-CoA. So for a 17-carbon long-chain fatty acid, we'd get 7 acetyl-CoA molecules, which is 17 minus 3 divided by 2, plus 1 propionyl-CoA. We can use this propionyl-CoA since it can become malate, then succinyl-CoA via propionyl-CoA carboxylase with biotin and methylmalonyl-CoA with vitamin B12, and be fed into either the citric acid cycle directly or gluconeogenesis. Excess malonyl-CoA, remember that we might have from fatty acid synthesis, inhibits carnitine acetyltransferase 1 and thus stops shuttling of fatty acids into the mitochondrial matrix. That covers the more common scenario of beta oxidation of saturated fatty acids, i.e. beta oxidation of fats stored via carbohydrate-mediated de novo biosynthesis or those from dietary saturated fats. But can we beta oxidize unsaturated fatty acids? The answer is yes, we just need additional enzymes and they may be worth less ATP. With regards to our monounsaturated fatty acids, we have an enzyme to first turn the cis double bond into a trans double bond, then move the double bond one space closer to the carboxylic acid head group, after which the accounting is the same. For polyunsaturated fatty acids, we'd need 2 enzymes for metabolism. First, enoyl-CoA isomerase to move the first double bond closest to the alpha carbon closer to the carboxylic acid. Then second, 2,4-dienoyl-CoA reductase, which removes the distal double bond entirely. These processes do not require calories or ATP, and thus the energy accounting and acetyl-CoA accounting after these processes is the same for saturated fatty acids. Just remember the difference with the odd-numbered chains. This highlights that while we cannot anabolize all types of fats, example omega-3 and 6 fatty acids are only obtainable in the diet, we can generally catabolize a wider variety of fatty acids with some extra steps involved. And importantly, this must be emphasized, unsaturated fatty acids may be worth less ATP, specifically if the position of the double bond is on an odd-numbered carbon. In this case, the enoyl-CoA isomerase enzyme bypasses the acyl-CoA dehydrogenase step during oxidation. We miss the first O step, and we don't produce FADH2. and lose out on 1.5 ATP. If located on an even-numbered carbon, we need NADPH for reduction. Thus, overall, keep in mind unsaturated fatty acids truly should be worth less ATP than saturated fatty acids. Let's review the overall accounting for the catabolism, specifically of palmitic acid. We'll need to activate the acyl-CoA, which costs us 2 ATP. The beta-oxidation cycle occurs 7 times, and we get 8 acetyl-CoA from it, which are each worth 10 ATP after all is said and done from the Krebs cycle and electron transport chain. Lastly, we have 7 times the cycle with 4 ATP each, thus 28 ATP plus 80 ATP minus 2 ATP is equal to 106 ATP total for palmitic acid. Of course, it's important to realize that with the multiplicity of enzymes required to enact these processes, both in the tagging, transport to the matrix, and beta oxidation itself, there are many places where gene mutations can lead to non-function and inherent inborn errors of metabolism that can be incompatible with life, or at least life-threatening, and require major dietary protocols to prevent catastrophe. Some of the major diseases to focus on would be primary carnitine deficiency, CP2 deficiency, and MCAD deficiency. Primary carnitine deficiency is a bit of a misnomer since the autosomal recessive disease results in inability to transport carnitine across the membrane to the cytosol, not removing carnitine altogether. As you'd expect, you can't get long-chain fatty acids into the matrix, but the problem is they accumulate in the cytosol, and this can cause failure to thrive, hypotonia, dilated cardiomyopathy, and death in neonates. But carnitine supplementation is definitive treatment. CP2, or carnitine acyltransferase, sometimes called palmitoyltransferase 2 deficiency, is another autosomal recessive problem which leads to inability to remove the carnitine once the acyl-CoA reaches the matrix, obviously leading to the same problem. It accumulates, unfortunately, in the mitochondria, and the same clinical presentation or death occurs. Treatment now requires to avoid long-chain fatty acids altogether and increase other sources of calories. Lastly, MCAD, or medium chain acyl dehydrogenase deficiency, involves inability to perform the O step in the OHOT of medium chain fatty acids, leading to accumulation and death via the same problem and hyperammonemia and liver failure. Treatment would involve simply avoiding most fats in the diet, since it is very difficult to avoid medium chain fatty acids explicitly. Most of these patients with inborn errors of metabolism, if caught early through routine screening, can live normal lifespans, but if not caught immediately, they are almost always lethal. Now remember, we've discussed that some organs in the body and cell types have evolved to only use carbohydrates. The central nervous system, for reasons previously stated, mostly because they need quick, rapid energy rather than slow energy sources to prevent neurological catastrophe, and storing fat inside the cranium may be disadvantageous, and the red blood cell, which lacks mitochondria, thus can't perform aerobic respiration and relies on glycolysis or gluconeogenesis in absence. While red blood cells are a special case, the central nervous system and other tissues in the body can use another metabolic backup product created by use of fat metabolites in acetyl-CoA to fuel their processes in ketone bodies. Ketogenesis refers to the process mainly in the liver of taking acetyl-CoA, already sort of a ketone with a sulfur atom, and removing the CoA component to stick it to another acetyl-CoA molecule to create HMG-CoA. This CoA can be cleaved off via HMG-CoA lyase to create acetoacetate, the prototypical ketone body. Acetoacetate and its metabolite, beta-hydroxybutyrate, qualify as these ketone bodies that characterize ketogenesis but are only produced in situations where carbohydrate access is low, since they function as emergency alternative energy sources in low-carb states. Thus, even in a caloric maintenance or surplus, ketogenesis could be achieved if the carbohydrate dietary intake was kept to 0 or trace, but ketogenesis in all comers is more common in fasting, even a little bit overnight, or starvation, where all fuel sources are low, and ketones are being made as a consequence of the involuntary carbohydrate restriction. Ketone bodies are unique in that they can cross the blood-brain barrier and be converted back into acetyl-CoA, where they can enter the Krebs cycle as substrates for the CNS. One acetoacetate or beta-hydroxybutyrate molecule ketone body provides approximately 22 ATP each for these cells. Insulin, or lack thereof, is the regulator of this process. When you have low carbs, you have low insulin, and thus minimal signal to store lipids. Instead, increased activity of the hormone-sensitive lipase, which removes fat stores from inside the adipocyte, liberating free fatty acids and allowing use in catabolism, and in this case, for ketogenesis. You can imagine pathological states exist where ketogenesis is observed. Starvation, as we've mentioned, but also in diabetes, aka diabetic ketoacidosis, where although there is dietary carbohydrate intake, extreme insulin resistance, or more commonly, complete lack of insulin in type 1 diabetes, leads to functional carbohydrate restriction in ketogenesis, but also alcoholic ketogenesis, where excess alcohol creates a lot of NADH as a result of its metabolism, shutting down the Krebs cycle and promoting formation of malate from the extra oxaloacetate, accumulating acetyl-CoA and promoting ketogenesis. Ketogenesis can be detected clinically via a urine test for ketones, but also a frank blood test for beta-hydroxybutyrate concentrations. Patients who are in ketosis may also be noted to have a fruity odor of acetone on their breath. Importantly, hepatocytes make ketones but cannot perform ketogenolysis, the catabolism of ketones, and therefore cannot use them for energy because they lack the thiophorase enzymes needed for the second step in the catabolic pathway. You may have heard about the ketogenic diet, really a low carbohydrate diet with multiple intended and postulated uses, including sports performance, obesity management, cognitive performance, but also more evidence-based medical practices like management of refractory epilepsies. Ketosis has clear biochemical consequences which may be advantageous in that lower carbohydrate diets can assist in a caloric deficit if fats and proteins are controlled, and they may be less stimulating to the nervous system, which could provide mechanism for their edge benefit in some forms of epilepsy. However, the ketogenic diet also can be tricky to tolerate and difficult to achieve practically. For obesity management, caloric restriction is equal in efficacy to carb restriction diets, and tracking overall calorie intake may be more practical than strict carb restriction. Now we have a much clearer overall picture of the order of operations with fuel metabolism and how our body will go about accessing fuel when needed. The two most important fuels being carbs and fats, ketones being a backup power source. Let's take a practical example of what happens to a marathon runner who then decides to starve themselves for days, as an impractical example. First source of energy that their body would go to is the reservoir of stored ATP, which is quickly depleted in 2 seconds as per our graph. In the next burst of energy, creatine phosphate, which carries a single phosphate for energy, can donate energy, but this is also quickly consumed, the rationale for creatine monophosphate supplementation in athletes. After this, we really need to start pulling from either one, circulating fuels, perhaps from those just ingested, or second, stored fuels, those in packaged forms like glycogen or adipose tissue. But in what order does this happen? Since glycogen is easier to obtain and glucose provides more rapid energy, it appears that hepatic glycogenolysis happens first with a burst of anaerobic metabolism using glycolysis, which requires no oxygen to obtain ATP. In addition to glycogenolysis, we will also try to make glucose for this purpose via gluconeogenesis, which we will discuss in the carbohydrate metabolism lecture. Only after this do we liberate stored fats and hormone-sensitive lipase, example with epinephrine or glucagon. Thus, fats are a long-term source of energy, but not the first pulled in high-effort situations. Now in the starvation situation, we have to think about energy depletion. Eventually, after only a few hours, most of our glycogen stores are depleted, and although gluconeogenesis can continue, we'll be starting to eat into our adipose tissue stores. Depending on your reservoir, this can last a while or not very long. Even while this fat storage removal is happening, ketogenesis begins occurring to support the CNS. Eventually, after days, protein consumption, i.e. muscle wasting, will have to occur to support the gluconeogenesis effort, and at this point, detrimental health effects may occur as a result of the ketogenesis and metabolic acidosis and the excess accumulation of nitrogen in the blood from protein breakdown. The average person can survive 1, maybe 2 months without food. Remember, in those who decide to fast for a variety of reasons, we can predict by this biochemical knowledge the order of fuel access and emphasize the importance of resistance training in those in whom protein breakdown in the skeletal muscle is likely to occur. So let's now try some lipid metabolism biochemistry practice questions to reinforce what we've learned. Question 1. Which of the following cellular metabolic processes would result in the highest net energy yield? Is it the glycolysis of 2 molecules of glucose, beta-oxidation of an unsaturated 20-carbon fatty acid, beta-oxidation of a saturated 20-carbon fatty acid, or both B and C? Hopefully you remember that, of course, glycolysis of 2 molecules of glucose without any further metabolism would lead to the least ATP generated out of everything, and you can't use NADH immediately for energy. Beta oxidation of the saturated 20-carbon fatty acid is expected to yield the most energy, and although the unsaturated 20-carbon fatty acid is largely metabolized in the same way, we miss the first O of the O-hot beta oxidation step depending on the orientation of certain unsaturated fatty acids. So the general rule is saturated fatty acids are generally worth more ATP than unsaturated fatty acids. Question 2. What is the rate limiting step of fatty acid synthesis? Is it the polymerization via fatty acid synthase, acetyl-CoA shuttling via the citrate shuttle, or reduction of ADP during the reaction catalyzed by malic enzyme, or the conversion of acetyl-CoA into malonyl-CoA via acetyl-CoA carboxylase? Hopefully you remember that the rate limiting step of fatty acid synthesis is in the cytoplasm, and it's that first step just before using the actual fatty acid synthase machinery, which is turning the 2-carbon molecule acetyl-CoA into malonyl-CoA via acetyl-CoA carboxylase, which of course uses biotin as a coenzyme. Question 3. Where does fatty acid synthesis occur in the cell? Is it in the mitochondria, the ribosomes, the cytoplasm, or the nucleus? Remember, the first step of fatty acid synthesis does require the citrate shuttle to get it outside of the mitochondria so we can produce NADPH to power the whole process. But ultimately, the fatty acid synthesis polymerization occurs in the cytoplasm. Question 4. What is the fate of the propionyl-CoA molecule generated by the oxidation of an odd-numbered saturated fatty acid? I'll give you a moment to take a look at these options. Hopefully you remember, of course, that we can take that 3-carbon molecule and transform it into malate, but then ultimately into succinyl-CoA, and succinyl-CoA can go into the citric acid cycle, but also into gluconeogenesis. In question 5, biotin is a key coenzyme for which of the following enzymes? And I kind of hinted at it before, but of course, every carboxylase enzyme is expected to use biotin as a cofactor, so the answer would be 1 and 3.